Obstetric hemorrhage is one of the common topics in obstetrics. It includes antepartum hemorrhage and postpartum hemorrhage. Antepartum hemorrhage is defined as bleeding of the genital tract from 20 weeks of gestational age until birth. And it affects 2 to 5% of all pregnancies, and it is 3 times commoner in multiparous compared to primiparous. Causes of antepartum hemorrhage include abruption of placenta, placenta previa, uterine rupture is a rare cause, vasa previa, and other causes, local causes, cervical ectropion, polyp, genital tract tumors, and unknown origin. Remember always when you have pregnant women presenting with antepartum hemorrhage not to do a PV. Don't do vaginal examination. No digital vaginal examination is allowed till you localize the placenta. Placental abruption is defined as premature separation of a normal-sighted placenta from the uterus. This is the uterine wall and this is the placenta. This is the uterine wall and the placenta has detached from the uterine wall. The prevalence in European countries is 3 to 6 per 1,000 pregnancies, and 70% of cases of placental abruption have been found in low-risk pregnancies. And abruption is usually an unanticipated pregnant emergency. Bleeding is usually concealed, and the prenatal mortality may be as high as 48%. The pathophysiology includes 2 potential mechanisms, acute inflammation and chronic vascular dysfunction. Bleeding begins in the decidua bisalis and leads to the separation of the placenta from its attachment to the uterine wall. This separation can be partial and self-limiting or can extend until there is fetal hypoxia and ultimately fetal demise. A Cavalier uterus where blood seeps through the uterine wall and it looks as a bruised uterus. And you can't see this in a vaginal delivery. We can see this only if we do a cesarean section. And the importance of a Cavalier uterus, that this uterus will be atonic after delivery, and this is a cause of postpartum hemorrhage because of atony. Placental abruption, the most common symptom is pain, abdominal pain. So whenever you have pregnant women presenting with abruption, think of presenting with pain, think of abruption. The most common cause of pain in pregnancy is labor pain. Of course, we're talking about late second and third trimesters. We're not talking about non-weekers presenting with abdominal pain. Don't tell me about a lady who's 9 weeks pregnant with abdominal pain that this is abruption. Of course not. Abruption, as we said, antepartum hemorrhage is from 20 weeks of pregnancy until delivery. The most important symptom of abruption is abdominal pain, and it is usually constant compared to labor pains, which are usually colicky on and off. Vaginal bleeding may be either concealed or revealed, but usually it is concealed with abruption. Contractions may be present either because the pain is because of labor pains, or it could be that abruptions stimulated labor to start, and this is why contractions are felt. Fetal distress, we check the fetal heart if there is evidence of variable decelerations or even intrauterine death in severe placental abruption. Disseminated intravascular coagulopathy, DIC, where you see women presenting with non-clotting vaginal bleeding or bleeding from rib sites and skin bruising. Think whenever you see this scenario that this lady has gone through DIC. And of course, maternal shock, maternal compromise. As we said, this is where the bleeding occurs under the decidual basalis and the bleeding is localized. This bleeding goes through all down and seeps through, and it presents with apparent vaginal bleeding. The bleeding can be often concealed or visible bleeding, antepartum hemorrhage. Remember, the main symptom of abruption is abdominal pain. On examination, look at the general condition of the patient. Is she well or not? And take the vital signs. Blood pressure is important, hypertension or hypotension, tachycardia. Then do the obstetric exam, Leopold maneuvers, symphysis fundal height, longitudinal lie, presenting part, previous scars, and check for uterine tenderness. If the tenderness is localized, this what goes with abruption, while with labor contractions, labor pains, the tenderness is generalized. And if there are uterine contractions, check are these normal, usual contractions or hypertonic contractions. Check the fetal heart and remember, with significant abruption, fetal death may be present in 15% of the cases. And abruption cases may end with labor, preterm labor or term. Classification based on the clinical presentation. Remember that pregnant women are usually healthy and they compensate for blood loss. So when there is 150 to 500 mils blood loss, this is grade 1. Clinically, there could be only a retroplacental clot at the time of delivery, and it can be incidental. The patient does not have any clinical symptoms. Grade 2, where there is retroplacental clot, 150 to 500 mils, but in association with anti-partum hemorrhage, but the baby will be alive. But there could be some evidence of variable decelerations. Grade 3A, where there is coagulopathy and fetal demise. 3B, no coagulopathy and fetal demise. Severe abruption is defined by retrospective study as an event accompanied by at least one of the following: maternal, fetal, or neonatal criteria. Maternal criteria: maternal problems, DIC, shock, blood transfusion, hysterectomy, renal failure, or death. Fetal, non-reassuring status or fetal death, neonatal death, preterm delivery, or small for gestational age. Abruption cases that did not qualify as being severe were classified as mild. Diagnosis is usually clinical, but do we need an ultrasound for diagnosis? Whenever you have a lady presenting with with antepartum hemorrhage, we said we need to avoid digital vaginal examination. No PV is allowed. and an ultrasound is mandatory. Why? To localize the placenta, to rule out placenta previa, confirm gestational age, and assess fetal viability, amount of liquor, and the presenting part. Retroplacental hematomas may be recognized in 2 to 25% of all abruptions, but recognition depends on the degree of hematoma and on the operator's skill level. So ultrasound is not used to diagnose abruption. Diagnosis of abruption is clinical, but the ultrasound is necessary to rule out placenta previa. We send bloods for CBC, full blood count, blood group and cross-match, kidney function, urea creatinine and electrolytes, liver function test, fibrinogen concentration, coagulation screen, and Kleihauer-Betke test to quantify the amount of fetal-maternal hemorrhage and decide the dose of anti-D required for Rh-negative women. Risk factors for abruption. The most important risk factor is a previous abruption. The risk of abruption is 10 times higher after one episode of abruption and 25% after 2 episodes. Other risk factors as folic acid deficiency, cocaine, smoking, hypertension, preeclampsia, thrombophilia, pre-labor rupture of the membrane, especially in prolonged pre-labor rupture of the membrane, multiple pregnancy, social deprivation, trauma, advanced maternal age, first trimester bleeding is a risk factor, low body mass index, and pregnancy following assisted reproduction techniques. Maternal complications include infection, this is with intervention, anemia, hypovolemic shock secondary to hemorrhage, DIC, acute renal failure, this is usually reversible, Cavalier Uterus, where this is a bruised uterus and this is a risk factor for postpartum hemorrhage. Postpartum hemorrhage is a complication, ischemic necrosis of distal organs, fetal-maternal hemorrhage, and psychological sequelae, especially with poor obstetric outcomes and intrauterine fetal death. Fetal complications include intrauterine fetal death, hypoxia and its sequelae, anemia, intrauterine growth restriction, and risks associated with preterm. Management depends on the amount of blood loss, if there is apparent bleeding, status of the mother and the fetus, and the gestational age. Always resuscitate as indication. We have the conservative option and delivery. If there is evidence of maternal or fetal jeopardy, then we deliver by emergency cesarean section. If pregnancy is term, mother and baby are stable, or the lady is in labor, we allow vaginal delivery. If preterm and stable, admission, conservative management, and give steroids. So, our target with abruption is to deliver vaginally if possible. We do emergency cesarean section if there is evidence of maternal or fetal stress. Otherwise, our target is vaginal delivery. At term, allow vaginal delivery. Preterm, stable, admission. Whenever women present with anti-partum hemorrhage, admit to the hospital for observation, even with minimal bleeding. Give steroids to stimulate fetal lung maturity and manage accordingly. Anti-D if Rh negative, and the dose will be as per the Kleihauer test. Placenta previa is defined as insertion of the placenta partially or fully in the lower uterine segment. This is the internal cervix. This is the cervix, this is the internal os, and this is the lower edge of the placenta. So this is a low-lying placenta. Distance between the lower edge of the placenta and internal os. This is reaching, this is partially covering, and this is completely covering the internal os. Lower uterine segment is usually formed at 28 weeks of pregnancy, and this is why we don't diagnose placenta previa before 28 weeks of pregnancy. Grades 1 and 2 are called minor placenta previa, 3 and 4 major placenta previa. The incidence of placenta previa varies according to the population we're studying, according to the cesarean section rate. But the rate of symptomatic placenta previa is really low, 0.4 and 0.8%. So usually patients with placenta previa are asymptomatic. When we do a routine ultrasound examination, we diagnose 5 to 28% of low placenta at the anomaly scan, but only 3% will continue to have placenta previa at term. Risk factors include previous placenta previa with a previous pregnancy, scarring of the uterus. Scarring could be either a previous cesarean section, D&C, or myomectomy. Artificial reproductive technique is another risk factor. Large placenta as in multiple pregnancy, abnormally shaped uterus, age more than 35, Asian, and smoking. Smoking is a risk factor for placenta previa and abruption. This to show you that the incidence of placenta previa is 0.26% when there is no history of cesarean sections, increases to 10% after 4 cesarean sections. Symptoms of placenta previa, the most important symptom is bleeding, and this is a painless vaginal bleeding. The blood is usually bright red, and it varies in amount from spotting to torrential, heavy, life-threatening bleeding. It can be a one episode or recurrent episodes, and it can be provoked by sexual intercourse or the onset of labor, and it can be associated with malpresentation in 35% of the cases, breech or transverse, and the fetus is usually well and in a good condition. Remember, when we have primiparous ladies at 38 weeks and you find a high presenting part, you have to think, what is there anything in the lower segment blocking the presenting part going through the pelvis? Think, is there a placenta previa? With malpresentations, breaches or transverse lies, please think again, could this be a placenta previa or not? And placenta previa usually presents late in pregnancy, by 36 weeks of pregnancy, not before, not early. The majority present by 36 weeks of pregnancy. On examination, again, general look of the patient, body mass index, vital signs, and the patient usually looks in a good condition depending on the amount of bleeding. She could be shocked if she's bleeding heavily. The presenting part is usually high, or it could be non-cephalic. It could be the lie, non-longitudinal lie. The uterus will be soft compared to a tender uterus with abruption. And as we said, always and always don't do digital examination, no PV is allowed till you localize the placenta. A speculum exam can be done by expert hands to assess the amount of bleeding and rule out local causes of the bleeding. Diagnosis requires, of course, clinical suspicion and then followed by an ultrasound. We do a transabdominal ultrasound usually to localize the placenta. If we have any suspicion, especially if the placenta is posterior, we may do a transvaginal scan, which is safe and more accurate and does not provoke vaginal bleeding. MRI is not routinely done because it is expensive and it does not offer extra information to transvaginal scan, but it may be required in cases where abnormal implantation as placenta accreta, increta, percreta is suspected. This is to show you, this is a transabdominal scan and this is a transvaginal scan. In a transabdominal scan, this is the bladder and this is the placenta, this is the presenting part. You can see in a transvaginal scan, this is the cervix and this is immediately the placenta. So the placenta is below, under the presenting part. Management of placenta previa. Do we need to admit all women with placenta previa? Not all patients require admission. We can manage them as outpatients, but this plan of care needs to be individualized according to the patient's risk, obstetric history, residence, is she away from the hospital, close by, and does she have easy access to the hospital or not. Remember, if you admit the patient to the hospital, think about the possibility of thrombosis. Pregnancy itself is a thrombogenic situation and admission to the hospital increases the risk of thrombosis. So think about thromboprophylaxis. And if there is antenatal anemia, this needs to be managed to prevent post-delivery complications and postpartum hemorrhage. Our target with placenta previa is to deliver by cesarean section. The question is, should it be an emergency or elective cesarean section? If the mother or the fetus show any evidence of stress, then we do an emergency cesarean section. If preterm, stable mother and fetus, then admit to the hospital, conservative management, observe vaginal bleeding, and give steroids to enhance fetal lung maturity. And if at term, unstable mother and baby, do elective cesarean section. So the delivery of placenta previa is always and always by cesarean section. Vaginal delivery is not allowed. The question is, should it be an emergency or elective? It can be also a scheduled cesarean section. Timing of the delivery depends on the grade of the placenta previa, usually between 36 to 37 weeks. We may go earlier than 37 weeks if the patient presents in labor, if there's any evidence of fetal distress, or if there is evidence of IUGR or intrauterine death, or the patient presents with severe bleeding or recurrent episodes of vaginal bleeding. In the case of suspected placenta accreta, usually delivery is before 36 to 37 weeks. The same applies to major placenta previa, where it is better to deliver by 36 weeks, sometimes earlier, to avoid delivering or doing an emergency cesarean section for major placenta previa, where there's high risk for postpartum hemorrhage. And always remember to give Rh negative patients, give them anti-D. Morbidly adherent placenta. This is an abnormal invasive placentation that can be categorized by depth of invasion. We have placenta accreta, where the chorionic villi attach directly to the myometrium in the absence of the decidua. We have placenta increta, where placental villi invade deeper into the myometrium but do not extend to the outermost layers of the uterus, and placenta accreta, where the chorionic villi penetrate through the myometrium up to the serosa. Here we have the placenta attached normally to the uterine wall, going through the decidua, this is accreta, and through the myometrium, but does not come out through the surface of the uterus, does not come out through the serosa. This is increta percreta if it goes beyond the serosa, and it may invade surrounding structures as the bladder. Pasa previa is defined as fetal vessels crossing the internal cervical os through the free placental membranes. The incidence is really low, 1 in 3,000 deliveries, and 60% of women with Pasa previa at delivery have placenta previa or low-lying placenta identified during the second trimester ultrasound scan. This is to show you, this is what we mean by Pasa previa, that the vessel itself is at the level of the internal os. This is with extra lobe of the placenta, and this is where there is membranous insertion of the cord. So it is the vessels, not the cord, that is below the presenting part. So it is not a cord presentation. We're not talking about cord prolapse. This is Pasa previa, where the vessels traverse the internal cervical os. This is to show you this is a normal placenta and the cord is attached. This is the membranous side attached to the center of the disc. And if you see this, the cord is attached to the membrane, and these vessels are the ones that traverse the internal os. Diagnosis is usually a combination. If we do antenatally transabdominal or a transvaginal color Doppler ultrasound, you may suspect it, but usually the classic triad for diagnosis is rupture membrane in association with painless vaginal bleeding and fetal bradycardia. Remember, the blood with Pasa previa is all and all fetal. The mother will be in a good condition, stable vital signs, painless vaginal bleeding after artificial rupture of the membrane. Think that this is fetal blood, and the risk for fetal death is really high. Risk factors for Pasa previa is filamentous insertion of the cord, accessory placental lobe, multiple pregnancy, and IVF. Management is emergency cesarean section, get the baby out as soon as possible, and complications, fetal death because of hypovolemia. The blood loss is usually fetal blood. Rupture uterus is a rare cause of anti-partum hemorrhage, and it is defined as full thickness loss of integrity of the uterine wall and visceral peritoneum. It occurs in 0.5 to 2 per 10,000 unscarred uterus and 7 per 10,000 vaginal birth after cesarean section. Unscarred, this means this lady never had a cesarean section. DNC, myomectomy, cesarean, this is the meaning of unscarred uterus. So the risk is really low. Risk factors include high parity, previous uterine surgery, scarred uterus, induction or augmentation of labor. This means that we're talking about probably hyperstimulation. where we have tetanic contractions. Malpresentation on its own is inadequate. Malpresentation in labor will lead to rupture uterus, macrosomia, uterine abnormalities, trauma as road traffic accident and obstetric maneuvers, and the risk of recurrence is around 5%. So if a previous rupture uterus occurred, then the chances are 5%. As we said, the lower uterine segment is formed by 28 weeks of pregnancy. Before that, we don't have a proper 28-week, we don't have a lower uterine segment. Unscarred uterus, the chances for rupture uterus 0.5 to 2 per 10,000. With a lower uterine segment cesarean section, the chances of rupture uterus, the risk is 0.5%, while with a classical cesarean section, the incidence is 5%. When we say a lower uterine segment, this means by 28 weeks of pregnancy, the lower uterine segment is formed, and this is where we do a smiley incision, which is called lower uterine segment cesarean section, and the incidence of rupture uterus is 0.5%. A classical cesarean where the incision is made in the upper segment, and the risk of rupture uterus is definitely much higher compared to lower uterine segment. Symptoms of rupture uterus are often non-specific, usually abdominal pain between uterine contractions. So the abdominal pain is continuous, and bleeding could be apparent or concealed. Loss of station, the fetal head will become higher. Inability to identify uterine contractions, and hematuria and blood-stained liquor. CTG abnormalities may show variable deceleration, complicated deceleration, and later on lost fetal heart if rupture uterus is not diagnosed and delivery is not done. Management of rupture uterus is ideally hysterectomy. It depends, of course, on the parity of the patient when we need to do a uterine repair, but the ideal management is hysterectomy. When hysterectomy is done, another obstetric consultant should be present for a second opinion. And complications of rupture uterus, of course, are maternal and fetal deaths. This is why it is important to save the mother, not the uterus. Whenever you have patients presenting with anti-partum hemorrhage, how should you approach this patient? First of all, you need to recognize, do I need to intervene urgently to manage maternal or fetal compromise or not? Ask about pain. Does this lady have pain or not? Painful antepartum hemorrhage differential diagnosis is different from the painless antepartum hemorrhage. Assess the amount of vaginal bleeding. Remember, with the vaginal bleeding, the apparent amount in cases of abruption does not mean that you can see all the bleeding. Concealed bleeding may be also present. Cardiovascular situation of the mother, stability of the baby, fetal well-being, CTG, and as we said, remember, bleeding can be concealed. If a patient presents with painless vaginal bleeding, you will think first of all of a placenta previa. What if she presents with a painful antepartum hemorrhage? Your first differential diagnosis is abruption, placental abruption. So does this mean that you can do a vaginal examination? Of course not. What you need to do is an ultrasound still to rule out placenta previa. Why is that? Because placental abruption and placenta previa may coexist in 10% of the cases. So always and always remember not to do a vaginal examination with antepartum hemorrhage till you localize the placenta by an ultrasound. When women present with antepartum hemorrhage, start by rapid assessment of both mother and the fetus, then quick history initially followed by detailed, confirm dates by ultrasound scan, and check the position of the placenta, assess the amount of bleeding, associated or initiating factors. Does the patient have abdominal pain? Is the abdominal pain constant or is it colicky like labor pain? Did the patient have intercourse? Is there a direct abdominal trauma? Of course, when women present with RTAs or direct abdominal trauma, even when the patient looks well and the fetus is well, no abdominal pain, please admit to the hospital for 48 to 72 hours for observation because of the risk of abruption. Ask about the leakage of fluid as in rupture of membrane and labor. Previous episode of bleeding during this pregnancy and previous pregnancies, previous obstetric complications, and if there was abruption in previous pregnancies or placenta previa, previous uterine surgery, smoking, medications, and always when you take an obstetric history, don't forget to ask the baby. You always ask about the mother and you forget the baby. Ask about fetal movement and ask the patient if she knows her blood group RH and if she had cervical smears in the past and if she's up to date and what was the last result. Assess maternal and fetal well-being, maternal vital signs, and then we do an abdominal exam, obstetric exam, look for previous scars, and Leopold maneuvers, looking for the symphysis fundal height, tenderness, lie, and presentation. We do not do vaginal examination. I keep repeating, no vaginal examination is allowed till a placenta is localized by an ultrasound and assess the amount of bleeding. To assess the fetal well-being, we do an ultrasound, check fetal heart by sonography. CTG cannot be done before 26 weeks. And to assess the fetal well-being, we are going to talk about fetal well-being and CTG cardiotocograph later. This is about antepartum hemorrhage. Antepartum hemorrhage is a risk factor for postpartum hemorrhage. Postpartum hemorrhage, the traditional definition of primary postpartum hemorrhage is the loss of 500 ml or more of blood from the genital tract within 24 hours of the birth of a baby. This can be either minor, when the blood loss is 500 to 1000 ml, major when it's more than 1 liter. Major can be divided into moderate and severe. Moderate 1 to 2 liters, and if it is more than 2 liters, this is severe postpartum hemorrhage. The definition of postpartum hemorrhage depends on the reference you're reading from, so there is some confusion about its definition. Some references define postpartum hemorrhage as more than 500 ml blood loss following vaginal delivery or 1 liter following a cesarean section, or a hematocrit drop of 10% or the need for blood transfusion. The incidence is 5% of all deliveries for primary postpartum hemorrhage. It could be defined also as excessive bleeding that makes patients symptomatic, as lightheadedness, vertigo, syncope, and signs of hypovolemia as hypotension, tachycardia, and oliguria. And remember, our patients are healthy, so when they're symptomatic, this means that they've lost significant amount of blood. This is just to show you with class 1 postpartum hemorrhage, you can see the patient lost 1 liter, which is 15%, but the symptoms are usually only mild dizziness, palpitation, minimal changes in the blood pressure, and with the 2-liter blood loss, there is significant tachycardia, pallor, cool extremities, hypotension, and the patient will be shocked when more than 2.5 liters of blood are lost. These patients, I repeat, are healthy. Usually they compensate, so it is very important to assess blood amount at the time of delivery to be able to diagnose postpartum hemorrhage in combination with the clinical picture of the patient. To estimate blood loss, it is very important to be vigilant with the blood coming out at the time of delivery. You need to familiarize yourself with every one of these to be able to recognize the blood loss. As in this picture, you can't tell me that this is only 200 mils. You have patients where the sheets, bed sheets, floor, clothes, everything is soaked with blood, and yet the resident comes out and says that the patient bled 200 milliliters. It is very important to estimate blood loss correctly, and this is the most important step in the diagnosis and management of postpartum hemorrhage. We have primary postpartum hemorrhage within the first 24 hours of delivery, and secondary where there is excessive vaginal bleeding from 24 hours after delivery up to 12 weeks postpartum. The older definition was 6 weeks, but this was increased to 12 weeks postpartum. The major causes of PPH are the 4 T's: tone, tissue, trauma, and thrombin. So postpartum hemorrhage is not the diagnosis. It is a symptom that requires a diagnosis. The diagnosis, as we said, with the possible causes: tone, tissue, trauma, or thrombin. Tone, abnormalities of the uterine contraction. The uterus will be atonic, and this is why patients will have postpartum hemorrhage. This accounts for 70% of the cases, in some references 90%. Risk factors for atony, for example, overdistension of the uterus, as in cases of polyhydramnios, multiple gestation and macrosomia, anatomical abnormality of the uterus, functional or anatomical, as precipitate labor or prolonged labor, infection, intraamniotic infection, chorioamnionitis with a prolonged rupture of the prolonged pre-labor rupture of the membrane, medications or bladder distension may cause atony. Tissue, we're talking about retained placental tissue or membranes and even blood clots. This is why after delivery it's a routine to make sure that the placenta is the placental cotyledons are complete and the membranes are complete. Trauma, especially when there is a precipitate labor, there will be lacerations to the cervix, vagina, and the perineum, or when there is instrumental delivery, if there is rupture uterus or uterine inversion, bleeding tendencies, abnormalities of coagulation, if there are pre-existing cases, or it can be acquired in pregnancy as thrombocytopenia of pregnancy, DIC as part of complications of sepsis, abruption, amniotic fluid embolism, or it can be patients who are already on heparin as an anticoagulant. Secondary postpartum hemorrhage is usually caused by infection, and the infection, endometritis, is usually due to retained placental tissue or membranes. It could be subinvolution of the placental site or pseudoaneurysms and AV malformation, and this cause is really rare. Prevention is important because when you evaluate your patients, you anticipate possible complications. If you have a patient with antepartum hemorrhage, you know that this patient will be at risk for postpartum hemorrhage, and this is why you do active management and give prophylactic uterotonics. A senior person will be involved. So anticipation is and prevention of postpartum hemorrhage is very important. Knowing the risk factors, you know this is an over-distended uterus, polyhydramnios, multiple pregnancy. This patient is at high risk of postpartum hemorrhage. Prepare the patient, put 2 IV cannulae, start the medication immediately after delivery to prevent postpartum hemorrhage. If postpartum hemorrhage occurs, remember it is always and always a teamwork. You are not going to save the patient on your own. It's a multidisciplinary effort. Obstetricians, nurses, anesthetists, all the team is required to be alert and diagnose and organize early, involve other services as the lab, blood bank, ICU in case this patient may require an ICU bed later, and involve other specialists as the hematologist, could be interventional radiologist as per the situation you're in. So when you have a postpartum hemorrhage, and this applies to all obstetric emergencies, the first thing you do is call for help. Always and always, whenever you're in an emergency situation, call for help. This is followed by ABC, airway, breathing, circulation. Of course, as I said, it is a teamwork. You're not going to do this on your own. You're going to manage the bleeding itself while others will help you with the ABC, insertion of 2 IV large bore cannulae, taking blood, sending bloods for CBC, clotting profile, liver function, kidney function, cross-match, prepare 4 to 6 units of blood, and start replacing fluids. Palpate the uterus. Before that, catheterize the bladder. You have an input and output. As we said, a full bladder may cause uterine atony. Palpate the uterus. Is it contracted or not? Is there evidence of atony or not? And if it is atony, we do bimanual compression and we start uterotonic medications. These uterotonic medications include syntocinon, which is oxytocin, ergometrin, the trade name is methergin. We don't give this for patients with hypertension or cardiac disease. Symptometrin is a combination, IM injection, combination of syntocinon and ergometrin. Hemabate is prostaglandin F2 alpha, which is once we reach the hemabate, we have to move to the theater. Misoprostol, which is cytotec given rectally to stop bleeding. It's a good practice to give misoprostol early in the course of the management of postpartum. Surgical management may be required, examination under anesthesia in the theater, examine the vagina and cervix to rule out lacerations and manage accordingly, do the appropriate repair, explore the uterus to rule out retained placenta and consider inserting intrauterine balloon tamponade as a first-line surgical measure where atony is the cause of the postpartum hemorrhage. This is bimanual compression of the uterus and to stimulate the uterus to become well contracted while we're giving the uterotonic medications. Check if the placenta is complete or not. Double and triple check the placenta. cotyledons and membranes, because retained tissues could cause atony and postpartum hemorrhage. If there is evidence of missed part of the placenta, then we have to remove the retained tissues in the theater. Look for vaginal and cervical causes, lacerations and tears that require repair. And insert a Bakri balloon inside the uterus. We inflate it with saline and we give uterotonics at the same time to keep the uterus well contracted. And after 24 hours, we start deflating the balloon and check that the uterus continues to be well contracted. Other surgical interventions include Belen suture. We do laparotomy, and we do a tie around the uterus to compress the uterus as if we are compressing to control postpartum hemorrhage. If the compression sutures are ineffective, then we do vascular ligation, stepwise uterine devascularization, and we may go to bilateral ligation of internal iliac arteries. Tranexamic acid may be used in the management of postpartum hemorrhage. It is cheap and effective in the management. Arterial embolization cannot be used for unstable patient. The patient should be stabilized first, and then we call the interventional radiologist to do arterial embolization. And this is why in cases of major placenta previa or suspicion of abnormal implantation of placenta, it is wise to prepare the patient for possible embolization. If she bleeds, then we can use the arterial embolization and control the bleeding. But if the patient is unstable, then this procedure cannot be done. Factor 7 can be used in the management of postpartum hemorrhage to enhance platelet aggregation and promote clotting through the extrinsic pathway. It controls bleeding rapidly within 10 minutes with minimal side effects, but the problem is its high cost. It is expensive. Hysterectomy is the definitive therapy where all the other interventions do not work, and as in cases of a refractory atony, irreparable uterine rupture or vascular injury or placental invasion, as in cases of abnormal implantation, placenta percreta. As I said, remember, our target is to save the mother, not the uterus. Complications of postpartum hemorrhage include Sheehan syndrome due to pituitary ischemia, and clinically the patient may not be able to breastfeed, infection because of interventions, disseminated intravascular coagulation, DIC, anemia, blood transfusion complications, hepatitis, and Asherman syndrome if we overcurate retained tissues. This will cause uterine adhesions. Whenever you have these situations, remember it is very important to document. Accurate documentation is essential, and then this should be followed by debriefing. Debriefing is usually done to the patient and her husband, to the couple, and also to the team, to the obstetric team that was involved in the management. And there is an opportunity for the obstetric team to discuss the events and to make sure that the best management was done, and if management can be done in a better way, to be done in the future. This is for you. You talked about DIC in your medical rotation. Stage 1 of DIC, hypercoagulable state, followed by consumptive hypercoagulable, and then secondary fibrinolytic state. Remember, active management of the third stage decreases the risk of postpartum hemorrhage. Always and always identify patients at risk and anticipate postpartum hemorrhage. Identify and diagnose postpartum hemorrhage as early as possible with accurate estimation of blood loss and manage immediately. Call for help and manage postpartum hemorrhage immediately.